There's a cardiac ultrasound, and I apologize for the quality here. For some reason, QPath is making this very disjointed. This is two views here where it's challenging for me to exactly see what's going on. It's a cardiac ultrasound. But then you move here to a parasternal short, and I think this is very helpful. This is the distal portion of the heart, where you see the more of the apex here in cross section and short, and then this is your RV here. And so it seems that the EF seems to be intact. But because I don't see the papillary muscles, I shouldn't comment on the ejection fraction. I need to see the papillary muscles in view. So you have to move the probe a little bit more towards the mitral valve so you can see that the papillary muscles in view, and then look at the ejection fraction. This is the last view that's saved in this application here, and again, I don't see the LV too well, I don't see the RV too well. The RA seems a little bit dilated, at least a little bit more dilated compared to the RV. I don't know the clinical significance of that, but that's just one thing to notice from this. So from the clip saved during this time, can't really tell much, can't really tell about the if there's a pericardial effusion or not. You can't really tell about the ejection fraction, though as I mentioned, this short, if I had to guess, will illustrate to me that the EF is intact, but again, it's too far towards the apex to really tell. Now, interestingly enough, this is the same patient but a different provider, and 2 hours later, and this is your cardiac ultrasound. It's oblique. I have the left ventricle and right ventricle in view, but what's concerning me is this right here, and this looks like a pericardial effusion. This here is either a very large fat pat, or sometimes this is what clot can look like, but this is concerning for a pericardial effusion. The only thing is that I don't see it in any of the other views, which is kind of interesting, and I don't have a good view of the descending aorta, so maybe this is a pleural effusion, but that does look like fluid. The question is, where is it located? The last thing about this clip is this is the only cardiac view saved at this timestamp, so it's hard for me to really see where this is. The last thing to talk about is what I believe is an IVC ultrasound, and I'm not going to lie, I'm not really sure of where we are in our orientation. I thought maybe this was the liver, but then why is there so much space here between the heart and the liver? So I'm not really sure exactly where we are. But one thing I do want to mention is that there was a measurement, and I personally think measuring the IVC is a waste of time. The measurement of the IVC corresponds to your ICP, which has been pretty much debunked pretty significantly in many papers and in a lot of studies. So I think measuring it, whether it's a half a centimeter, 1.5 centimeters, doesn't help. I think what does help is if it collapses or not. If you have that the IVC completely collapses, I think you could safely give a patient volume. If it does not collapse, I think you're still in a gray area, because that could be from a pericardial effusion, it could be from a PE, it could be from RV failure. There's a lot that can cause a non-collapsing IVC, which is why I'm trying to push people to do both an echo and IVC at the same time. So main take-home points are difficult to see the cardiac views, which is fine, that happens, but I was concerned for a possible pericardial effusion there, and again, I don't know the significance of it, and also with the IVC. Again, I just think eyeballing it, seeing if it collapses or not, is a much better test than measuring its diameter. So hope this helps. Sorry it's a long video. Thanks for saving.